Hello, friends. Welcome to this session of critical care training. The topic for today's discussion is one of the most frequent neuro-psychiatric disorder seen in critically ill patient or otherwise hospitalized patient is delirium. The learning objective for this session will be to understand the definition, various terminologies used in this regard, incidence and effects on outcome in particularly critically ill patients. What are the various subtypes of delirium? What are the risk factors? The underlying pathophysiology and how we deal with this? What is the monitoring required and step towards prevention? If we come to the term acute confusional state, acute brain syndrome, acute brain failure, ICU psychosis, these are the various terms which you use in day-to-day practice by the intensivist physician. If the patient is altered, we call it sometimes toxic confusional state, or patient is in toxic encephalopathy. These all terminologies, if we define, they are nothing but delirium, which is by DSM-5 criteria can be recognized as disturbance in attention, awareness, cognition of the patient, and that too over a short period of time and fluctuating in course. The prerequisite is this disturbance is unexplained by any previous neurocognitive disorder. So the dementia, which is a progressive loss, does not uh, categorize as a delirium. It does not occur in context of severely reduced level of arousal, and evidence that disturbance is direct physiological consequence of other medical conditions like substance intoxication or withdrawal. The most common we see is hyperactive delirium, that is delirium tremens in cases of withdrawal. What is the incidence? If we screen the Western data, the incidence has been from 22 to 80% in various, depending upon the medical setting, depending upon the patient, whether mechanically ventilated, non-ventilated. So there is wide range of variations. If we see the Indian study, one of the Indian study which was done at our center, which showed the incidence around 22.11% in this tertiary care center, and the mortality was also significantly high. At the same time, the length of stay and the effect on complication was much more higher when we compare the Indian data. These were some of the complications which we observed in our study. In hyperactive delirium, which you see removal of the catheter, aspirations, requirement for reintubation, decubitus ulcer. As I said, the length of stay and hospital length of stay is both increased, and mortality also shows a significant increase in a delirious patient when compared to a non-delirium group. So this is an important medical condition which need to be identified and prevented. It definitely adds to the healthcare cost which the patient and the caregivers are has to bear the cost. So this is very relevant. If we see subtypes of delirium, the most important one here is a hypoactive delirium where the patient is lethargic, drowsy, and infrequent movements which we often miss unless we screen it. And then the other type is hyperactive where there is a risk to the staff, risk to the patient himself, risk of fall, risk of self-extubation, pulling of lines and catheters, which is most commonly seen in mostly substance withdrawal, and also sometimes mixed type where there is an alternating period of hypoactive and hyperactive predominant presentation. What are the patients at risk of developing delirium? If we see, these are usually the elderly patients, the immunocompromised patients with HIV, Major surgical operation like post-cardiotomy or patient with severe burn injury or patient with pre-existing brain damage or those who are on drug-dependent patients. So these are the patients which we should screen early and prevent the development of delirium. What are the risk factors? If we see the modifiable risk factors from the ICU environment, like the lack of visitors during COVID period that precipitated delirium in patients, immobility, gastric tube, sleep deprivation is a major problem, noise in the ICU, the decibels are high, it also leads to delirium. Number of medical conditions like anemia, hypotension, infection, SIRS, azotemia, need for mechanical ventilation itself increases the risk. Similarly, if the patient's age is more than 60, he has a history of substance abuse, and even the genetic factor like APOE4 protein deficiency, hearing or vision impairment can lead to delirium. What is the pathophysiology? It is mainly the imbalance in the neurotransmitter, and we see that there is a lot of medical condition in which there is inflammation, and the brain also develop the acute cytokine excess leads to this brain dysfunction. Similarly, the dopamine activation, the cholinergic activation, or serotonin deficiency, cortisol excess, GABA activity, or glutamate activation. So you see so many neurotransmitter imbalance can lead to this potential complication of delirium. Sedatives are commonly used in ICU to calm the patient on ventilator. This was a study which showed that the probability of delirium increases with these sedatives like lorazepam, and similarly in surgical and trauma patient who received midazolam daily has significant higher number of patients who were delirious compared to those who did not receive the sedatives. So they affects the uh, incidence of delirium increased by this use of sedatives. So they should be avoided. What are the other emergent conditions in the ICU? The mnemonic is WIMP, where like wernicke's encephalopathy, where there is ataxia, ophthalmoplegia, alcohol history, sympathetic overactivity. Patient may present as delirium. Treatment should be treated with thiamine and glucose. If the patient is hypertensive encephalopathy or the insulin dependent diabetes mellitus with hypoglycemia, hypoperfusion to the brain because of decreased cardiac output, hypoxemia, pulmonary disease. So patient is delirious, saturation is down, it's hypoxic. So you have to correct that. Intracranial bleed or infection, meningitis. Sometimes the SH patient will be irritable. Meningitis patient will be irritable and will be delirious. So these potential conditions or emergent conditions should be looked for and screened for and treated if we look for the reversible causes. Similarly, other causes, other mnemonic which is commonly used is I watch death, that is I is infectious causes. Look for withdrawal, look in nursing notes, look for the family history, look for metabolic conditions like acidosis, electrolyte disturbance, hyponatremia, history of trauma, CNS pathology, whether the patient has seizure or non-convulsive seizure, or he is hypoxic, are there vitamin deficiency, endocrinopathy, toxins, or heavy metals if the patient is on some Ayurvedic medicines. Sometimes the iatrogenic drugs, which are very commonly used in ICU, can cause delirium, like the antibiotics which we use, like chloroquine, the common antimalarial, tetracyclines, aminoglycoside antibiotics, steroids or atropine. We have seen atropine toxicity in patients with OPP become delirious. Amantadine or carbidopa, levodopa, these are anti-Parkinson drug excess, valproic acid, digitalis, or other symptomatic drug like aminophylline can stimulate CNS stimulation, and the ranitidine lithium, baclofen, all these drugs can precipitate delirium. So we should checklist these medicines as a cause. So it is very important to screen for delirium, and the standard approach which is mentioned is first to assess the sedation scale in the ICU, that is the various sedation scale, Ramsay scale, Richmond agitation sedation scale, which is shown here. Any score above -2, where above 0 it shows the excessive activity, like patient is anxious, +2 is frequent non-purposeful, +3 is aggressive, +4 is combative. And if 0 is alert and calm, -1 is awakens to voice, and -2 is briefly awakens to voice. -3, -4, and -5 are moderate sedation, deep sedation, unarousable, where we cannot go to the second level of screening. So above -2 patient, even if they are on ventilator, we have a very validated scale of confusion assessment method in ICU with sensitivity of around 89 to 100% and specificity of 93 to 100%, which assess the delirium for the four main features. And the scale has been, which has to be used in step 2, has been translated in almost 17 languages. One of them is also in the regional language Hindi and Marathi, which I saw, and which can be very easy to administer even by the paramedic or the nurses. So first feature is acute change or fluctuating course of mental illness, whether it is present within last 24 hours. If the answer is yes, then the next part has to be seen is at inattention, where you can say a word like save heart and ask him to squeeze the hand at letter A, or you can use a regional language for this. And if there are 0 to 2 errors only, then the CAM is negative. However, if there is more than 2 error, you go to the next level of consciousness to decide whether it's hyperactive, hypoactive, and a RAS scale you have to check. If RAS is other than 0, then CAM ICU is positive for delirium. If RAS is equal to 0 and patient, you look for the disorganized thinking, where you ask him simple questions like whether the stone will float on water, are there fish in the sea, does 1 pound weigh more than two, or can you use a hammer to pound nail, or give him command to show the fingers, or add one more finger, you can say that, or you can give simple bedside command to screen, like mini mental state examination can be used, or sometimes dysgraphia is the most common, where you ask the patient to simply draw a clock and the time and he's unable to draw it. This also is a sensitive test to see for the delirium, where you can screen with these scales. So the prevention is the answer. So what is the things which we can do is identify the and modify the risk factor, monitor the noise in the ICU, avoid sleep deprivation, frequent reorientation by the family members, avoid dehydration, adequate oxygen and blood pressure control. Early mobilization is the key, removing the restraints and catheters. If the patient is elderly, visual and hearing aid to him. And if at all the sedation is required, the newer sedative agent like alpha 2 agonist dexmedetomidine has been shown promising with less risk of delirium compared to midazolam. What is the treatment? Treatment lies in prevention. So meticulous screening, avoid the physical restraint, pharmacotherapy agents. The most common one which cause less respiratory depression is haloperidol. Atypical agents like olanzapine, risperidone, quetiapine can be used. Do not use benzodiazepines, but with haloperidol, you have to be carefully monitoring the ECG for QT interval so that it should not cause the QT prolongation, and maximal dose is 20 milligram per day. So suggested guidelines for haloperidol use is, if the level of agitation is mild, you can use the tablet form 0.5 to 2 milligram, or if it's moderate, you can go to 2 to 5 milligrams. Severe, cases may require 5 to 10 milligrams. With the IV line with NS, give 0.5 to 2, allow 20 to 30 minutes, check for the QT interval. This is for the nurses, you can give a protocol. If continued agitation is present after 3 doses, then the 1 milligram of lorazepam, alternate with haloperidol every 30 minutes. And total amount of haloperidol once it's calm, not more than 20 milligram per day. Give the dose over 24 hours, and if the patient remain calm, you can reduce it 50% every 24 hours. Remember, the oral dose is of course twice the IV dose. What are the outcome? We have seen the local complication, immediate complication like self-extubation, self-harm, removal of catheter, ventilated pneumonia, prolonged ICU stay, and prolonged ICU stay with mortality is significantly high in various studies, and long-term effect like cognitive impairment in these kind of patients with a history of delirium during the ICU stay is common. So in summary, delirium is highly prevalent in ICU setting. It occurs, causes significant morbidity and mortality, adds to the primary disease, adds to the cost for the caregiver. Daily screening with validated tool like confusion assessment method ICU must be practiced, or a local scale like dysgraphia, as I told, mini mental state examination, early identification, prevention of risk factors, and checking the medication chart to prevent delirium drug and modification of sedation practices should be considered. Thank you for patient listening.